Hello everyone. Welcome to today's session of Physio TV titled Thoracic Pain, What Should We Look Out For? Spinal pain in the workplace has been identified as major occupational health problem, but thoracic spine pain has rarely been assessed. Compared to lumbar and cervical spine, thoracic spine has received very much less attention. Thoracic spine is a common site for inflammatory, degenerative, metabolic, infective, and neoplastic conditions, which may also contribute to pain and disability. Studies have shown prevalence of thoracic pain to be between 7% and 38%, but still there is lack of evidence and knowledge in risk factors causing thoracic pain. Therefore, we need more information about this particular topic to understand it well. So moving on, I'm honored to introduce our today's speaker, Dr. Mangesh Deore, who is currently practicing as an advanced orthopedic physiotherapy practitioner in Balton NHS Foundation Trust, UK. He is Masters in Musculoskeletal Physiotherapy. He has also worked as a spinal physiotherapist in Greater Manchester NHS. He is also certified in injection therapy, understanding behavioral change and health improvement, and also certified in orthopedic radiology. He has publications in national and international journals, and he has clinical experience of around 30 years. So, welcome, sir. I would like to, yes, I would like to hand it over to you, sir. Thank you.
Thank you very much, and thank you for having me. It's been an honor. I've been a student of physiotherapy at Sancheti for between 2003 and 7. It brings really fond memories, so I'm really grateful for the opportunity. I won't waste more of your time. I'll just get on with the talk, I think. So as I was introduced, my name is Mangesh. I work in the UK as an advanced orthopedic practitioner. I'll give you a bit of a background of this role. This role is goes slightly beyond the traditional role of physiotherapy. That means it involves a lot of diagnosing and managing pain non-surgically. So it's quite a bit of there's quite a bit of risk factor in terms of the assessments that we have to do, and that's when I realized that thoracic pain is something that has not been as well assessed or well looked after as compared to cervical and lumbar spine. And hence, I think when I was speaking with Sora ma'am, I think I just suggested whether we can discuss this a little bit. So when we assess thoracic spinal pain, there are some key considerations. I think I'll just make this as a full screen. Sorry, just bear with me. Yeah. So there are basic key considerations when it comes to thoracic spinal pain. And just talking about the basics of anatomy, because that plays a vital role in assessing, diagnosing, and understanding the problem. So obviously, we all know that we have 12 vertebrae in the thoracic spine. And they often tend to say that more the vertebrae, more problems you can have, more differences you can have. So I think that's something to bear in mind, that there are also connections with the ribs, and obviously costovertebral joints play an important part. And the peculiarity here is the blood supply and the neurological structures here as well that we have to be mindful of. Of course, we know it's semi-rigid. Thoracic spinal, the thoracic spine is not as mobile as cervical and the lumbar spine. So functionally, going back to the basics again, it serves in stabilizing the spine. It helps in attaching the rib cage, and it also provides protection posteriorly as opposed to movements. So protection is one big thing in terms of its functionality. And as I said, it does have implications in how we assess it. And we also know that spinal cord is the tightest in thoracic spine. That what I mean by that is the lumen or the spinal canal is narrowest here, and that usually tends to make the spinal cord slightly bit more vulnerable. As you can imagine, it's rigid; it doesn't have a lot of space to move. In addition, it's a bit tight. When it comes to trauma of the thoracic spine, we have to be a bit careful in assessing and interpreting things. And another peculiar thing within the spinal medicine is obviously vascular supply between T9 and T11 is a bit precarious. It's a bit lower compared to the other parts of the thoracic spine. So that plays a role as well. And this junction of thoracic spine is also a transitional junction with the lumbar spine, and it is more prone to trauma. It's got less blood supplies and the tighter spinal cord. So these factors, I think, we have to consider when it comes to thoracic spine as basics. We were discussing earlier, obviously, there are traumatic and non-traumatic causes of thoracic spinal pain, and it makes it a bit simpler when it comes to classifying the pain. And because traumatic pain is down to, it leads to fractures, and thoracic spinal vertebrae tend to get fractured a bit easier compared to the lumbar and the cervical spine due to its lack of mobility. And of course, there are non-fracture traumatic issues as well. Sometimes you can strain the facet joints, costovertebral joints, can strain the muscles, and so on. So these are less serious traumatic causes. And then non-traumatic factors. And personally, as a clinician, I think I get slightly more concerned when the thoracic spinal pain is a bit non-traumatic. Because there are mechanical causes which are non-serious. That's okay. Degenerative, which are like spondylotic changes, your facet joints become a bit arthritic. That's fine. We'll come to its assessment in a minute, but I'll just broadly categorize that into causalities of the pain. Neuromusculoskeletal is one important aspect as well, because we all know neuromusculoskeletal issues lead to primary deformities like kyphosis. There are some young age kyphotic deformities which require implants and corrections and so on. Schomann's disease is one thing as well. It where you tend to see the wedging of the thoracic vertebrae. The thoracic body is a bit more flexed, and it leads to kyphotic deformities. That leads to some mechanical pain as well. But Schomann's disease, again, it's not a very serious cause for concern. It's something to be mindful of, that's all. And then we have inflammatory conditions like ankylosing spondylosis. There are some rheumatoid conditions that we have to be mindful of. Neoplastic, which is your cancers. Now this is something that in recent years has received a lot of attention, because when patients tend to have a cancerous pathology in the spine, it tends to be more commonly found in thoracic spine, and that's down to and this is why I was talking about the anatomy, which is so important. The spinal cord is very tight there. The vascular supply is a bit peculiar as well. So the hematogenous, which is blood spread and direct spread, it has easier routes in thoracic spine, and hence that's one of the hypotheses why cancers tend to be a bit more of the site when it comes to thoracic spine within the spinal world, if you like. And infective, of course, you've got your things such as TB, discitis, and so on. These are broadly speaking the causes. Now, going to the assessment of thoracic spine, it's something that when we talk about spinal assessment, we barely talk about thoracic spine as a full entity when it comes to assessment. And I do feel, considering the nature of the thoracic spinal issues, that's a very vital part, that we have to consider. It's very important because uh, the assessment for thoracic spine is, it has more to it than what it meets the eye. And that's why thorough history is very important. We have to ask them whether it's traumatic or non-traumatic onset. If they've had trauma and they've had fracture, then obviously the diagnosis becomes very clear, and then the management becomes a bit clear. Non-traumatic onset, as I said, and then when the patient said they've been getting thoracic spinal pain and there has not been any significant trauma, then you will ask the next step, which is whether the onset was gradual or sudden. Personally, I think gradually worsening pain is something that I would get more concerned about than sudden pain, which is staying there for a number of months or even for weeks, and no patient is not having any neurological symptoms. So gradually worsening pain is something that we have to be a bit, careful about, and it needs a bit more of an assessment. Um, One thing peculiar about, again, thoracic spinal pain is the night pain. The importance of asking night pain in thoracic spine is, I cannot overstate at all, because obviously it's uh, the way thoracic spine or any spinal conditions works is obviously, when there is an inflammatory component, the pain is um, worse at night, and you don't get pain without inflammation. So um, the reason for that is obviously at night your inflammatory mark is a bit higher. We don't have natural hormones that we have during the day at night, and that's why your inflammation always, it's circadian rhythm. So inflammation is always a bit higher at night, and you tend to feel the pain a bit more at night. And when that's the case, and the pain becomes unremitting, quite severe at night, it's usually a cause for concern. If they say at night, I'm not too concerned, I can sleep okay. I have no issues with my sleep. In fact, if I rest, pain feels better. It's very reassuring. So it's not something that I'd be worried about. It's when the pain gets worse at night. That's something that we have to be mindful about. And whether the patients are able to lie in supine or not, that's an important thing, because when patients are not able to lie in supine, that's usually a sign of significant issues with the vertebrae themselves. Is because it's a very rigid column. It's trying to straighten within its available range, and it just cannot straighten up, and the pain becomes quite severe. Yeah, so not being able to lie supine is one of the worrying factors as well. And then you would ask about neurological symptoms, whether the pain is radicular, whether it's non-radicular. If the pain is of neurological, so the patients feel their legs feel a bit different. They tend to have some sort of paresthesia in their legs, but they do not follow it in your radicular pattern. That is something that we have to be careful about as well. Excuse me. And then we asked about the balance, because it is usually controlled by, of course, the brain, but also the tracts. They come through the spinal cord. If patients are saying they're getting quite severe thoracic spinal pain with balance issues, then we're talking about probably involvement of spinal cord, and hence walking balance is important. Bowel or bladder incontinence with retention, because if there is compression on the spinal cord along with pain, then obviously the sphincter is not able to relax. It's the upper motor neuron issue or the problem, and that would inhibit the lower motors, and obviously the sphincter won't be able to relax, and if patients tend to get a lot of retention sort of symptoms. which again is quite worrying factor. And then you'd ask about history of tuberculosis, cancer, and osteoporosis. Tuberculosis, obviously, because of port spine. I think we all know about port spine. History of cancer. If they've had history of cancer and they're getting quite severe thoracic pain, I think it warrants more investigations. And I'd speak with the spinal consultants or the surgeons first before doing any sort of treatment, of physiotherapy and things like that. Osteoporosis, of course, it goes without saying. We have to be very careful when there is a documented history of osteoporosis. Obviously, just to make sure that they have no wedging sort of compression fractures or anything of that sort. So the history is quite important, mainly to rule out these serious problems. So if they say no to all these things, for instance, they say they no to night pain, able to lie in supine, which is good. Neurological symptoms they don't have neurological symptoms. Walking balance is okay. They have no issues with incontinence or any neurological symptoms, and there's no history of TB, cancer, osteoporosis. Then it is very reassuring. And then physiotherapy measures and go forward with bit more freedom. So that's a thorough history is extremely important. And in objective assessment, you look for any deformities, any wasting of lower limbs, which is quite important. And gait is extremely important when it comes to thoracic spinal assessment, because if they have significant thoracic spinal pain with some lack of balance in their gait or ataxia, then again it tells us a bit more about spinal cord involvement, and we have to be very mindful of these things. So when the new picture becomes a bit more neurological, it is something we need to be a bit careful about. And palpation, obviously, centrally over the vertebrae, if to rule out any sort of bone contusions or fractures, or and then facet joints, costovertebral joints. That's our bread and butter. I think that's okay. I think everybody knows about importance of palpation just to localize the structures. I personally think the most important aspect of thoracic spinal pain is the neurological examination, and it's to rule out upper motor neuron signs such as hyperreflexia, balance issues, clonus is positive, plantars are upgoing. These are the things which would worry me personally. And if the neurological assessment is okay, then it is again a bit reassuring. It's so when all these assessment is done, then I think we can come to differentials as to what we are thinking about in terms of diagnosing thoracic spinal pain. If they have neurological symptoms, if they have balance issues, then we're talking about it's more than a thoracic spinal simple mechanical issue, and then we have to be a bit more concerned and probably speak with the surgeons or your clinical leads or your seniors if possible. There are some red flags. What I mean by red flags is obviously these are the symptoms which should be cause for concern. Okay, and if patients have a combination of these, then it is something that requires further investigations. And or to put it other way, if they don't have red flags, which I'll discuss in a minute, then our assessment, our management, again, can go a bit more freely. So things that we really have to look out for, that's the title of the talk, is number one, unremitting constant pain. That's a measure of some sort of bone involvement, vertebral involvement, some nerve root involvement, and quite high degree of inflammatory response within the thoracic spine at some site. As I mentioned earlier, severe night pain. So when you ask in the subjective history, I think we have to ask about these red flags. So I personally ask the patients, do you get quite severe, constant severe pain, which is not relieved on rest or with painkillers? And if they say yes, then I would say yes, they've got unremitting constant pain. Do they have severe night pain? It's affecting their sleep. That's another red flag. Uh, Again, as I mentioned earlier, difficulties like in supine is one of the red flags as well. The next one is band-like pain, which is a tightness across the chest wall, and that's down to the nerve roots in the thoracic spine, and obviously the nerve roots which come into the rib cage into intercostal muscles. If those nerve roots are involved, patients tend to get quite severe band-like tightness, as if the any belt is being squeezed across their chest, and that again is a worrying sign. Um, Evening or night fever. Now this is, I think we all know this. This is usually a sign of some sort of an infective pathology, and if they say that they've got it and they have history of uh, TB, then obviously the focus of attention should be to rule out anything tuberculous. And then we speak with this specialist surgeons or again your clinical leads or seniors as you feel appropriate. Um, Unexplained acute weight loss is quite important, and the measure of weight loss is quite important. If the weight loss is more than 10% of their body weight over a period of 4 to 6 weeks, then that's quite an important red flag, which is quite a worrying clinical symptom. So, say somebody weighs 70 kilograms, and if they say they've lost 10%, say around 7 to 8 kilograms over a period of 1 to 2 months, and then in that case, yes, it is a red flag. Um, Loss of appetite or malaise. Loss of appetite again is a sign of something inflammatory going on. That could be something infective or even cancerous sometimes. Drenched in night sweats. They wake up in the middle of the night. They have to actually change their clothes and their bed sheets, etc. That is a red flag as well. Now, altered sensations in the legs. I touched upon it a few minutes ago. That's usually a sign of some sort of neurological involvement in the spinal cord. That is quite important as well. Loss of balance is again a function of that's a sign of spinal cord getting involved, and of course history of TB, cancer, osteoporosis. So these are the symptoms that you would always ask for, whether they have it or whether they don't have it. If they say no to most of these, then it is very reassuring. And then you can say, yeah, probably we are looking at the end of your subjective examination or at the end of your history, we're probably looking at, yes, this is a non-serious, probably mechanical, kind of facet joint related muscular issue in the thoracic spine, and physiotherapy interventions like we all do, they can continue based on the assessment and so on, depending on the muscles and the joints involved. The now red flag of the signs is altered gait. If the gait is affected when you start to examine the patient, if the gait is quite affected, and they can't balance with their eyes closed, that's again a sign of some sort of spinal cord involvement. The sensations when you assess the neurological exam, neurologically, often with thoracic spinal pain, if the neurological involvement is there, then the assessment does not follow a dermatomal pattern as you would follow in the lumbar spine. For instance, in lumbar spine, if the altered sensations are in L5 dermatome, or if their EHL is weak, then you say yes, it's L5 nerve root impingement. But in thoracic spine, because spinal cord tends to get a bit involved, and there is a bunch of tracts and a bunch of nerve roots before they come out into the spine, the sensations are very patchy. So sometimes they'll feel, yeah, my thigh feels a bit different on assessment along with the other side of the foot. So there's no combination, there's no pattern to it. So they're very patchy sort of sensation. They often may not have weakness of their legs or myotomal weakness. Um, uh, and the reflexes, however, if they have got hyperreflexia, uh, and hyperreflexia means, I think none of us will be able to miss it. It is that kind of severe hyperreflexia. And when you assess the clonus, if there are 7 to 10 beats per second, that tells us that spinal cord is quite significantly involved, and that again is a red flag. Planters are outgoing, which is again a promoter neuron sign. Rhombus sign is positive; they can't balance. Um, Hoffman's reflex is when you flick their thumb and their finger is flexing. I'm sure. I mean, Hoffman's reflex is routinely getting assessed now. But if you haven't been, I would advise everybody to do the science behind Hoffman's reflex. It's quite important. Uh, I think that goes slightly beyond the talk today, but I would ask you to routinely perform Hoffman's reflex. If you're not doing it, then my advice is to try and do it for cervical and thoracic spinal examination, because that's usually positive Hoffman reflex is a sign of spinal cord involvement. Uh, of course, and there are some non-spinal causes we have to be aware of. To be honest, I think this is extremely rare to see in a musculoskeletal, orthopedic, or physiotherapy clinic, um, because the pain pattern is quite different. Often, the other clinicians and general medicine practitioners, they will assess it. They'll be able to take it, diagnose it then before they're being seen by us at all. So, and there are some non-spinal causes which will then cause thoracic spinal pain. Aortic dissection that causes quite severe thoracic spinal pain, but it's an emergency. It's unlikely that we'll see this in a routine outpatient case. So I wouldn't worry about this too much, but it's something to know, uh, good to know about. Aneurysms, thoracic aortic aneurysms can cause quite severe referred pain into the thoracic spine. That is something we have to be mindful of. Respiratory conditions, however, quite commonly cause thoracic spinal pain. So if neurological assessment is okay, if they're able to lie supine, they don't have severe night pain, then I would do a very quick respiratory assessment as well. Just auscultate their spine, ask them about if they're getting any cough, productive sputum, if they have any, I would percuss them and see if there is any change on either sides. If it's a dull percussion or hollow, I would do a very quick respiratory examination with auscultation as well. And because pleural pain quite commonly, it is more common than we think, uh, can cause quite significant thoracic spinal pain. And it tends to radiate across the chest wall a little bit. So it is very, very easy to assume that it's a muscular, simple thoracic spinal pain. And as we discussed earlier, the overall, kind of percentage of thoracic spinal pain within spinal problems is anywhere between 7 to 39%. And out of that, probably 10 to 15%, uh, um, are non-spinal or respiratory issues. Again, they're not emergency, but something I routinely assess their. If neurological exam and everything is okay, they don't have other so-called red flags, then I would ask their respiratory as well, just to be sure that there is nothing non-musculoskeletal we're looking at. And then we have non-specific thoracic spinal pain, so-called simple back pain. I know no back pain is very simple, in terms of the symptoms it causes. It may be fairly simple to treat sometimes. Advise management, regular exercises. You can ask them to improve their cardiovascular kind of tolerance. There are some basic muscular issues like rhomboids, latissimus dorsi. They get often neglected when it comes to assessment of muscular thoracic spinal pain. The fossa joint pains are quite irritable when it comes because of the capsule of the thoracic spine is rich in nerve endings, so it can give quite significant fossa joint pain. Um, so, if it is quite localized onto either side of the spine, left or the right, or even both for that matter, without any neurological symptoms, without any referred pain into the chest wall, then you can assume yes, it's fossa joint pain, and you can try and treat it accordingly. Um, and costovertebral joints as well. This is a bit less common, but pain tends to be quite activity dependent. Also, deep breathing can cause sharp pain there as well. Again, that's similar to the pleuritic pain as well sometimes, and that's why respiratory assessment, going back to the same point, I think it is quite important. But if they have no respiratory issues, and as I said, neurological examination is clear, the costovertebral joints would be the working diagnosis. Uh, so summary is just to summarize everything. I think in thoracic spinal pain, thorough history is very important when it comes to diagnosing them and managing them. The problem with thoracic spine is, as compared to the other spines, we in thoracic spine there is more to rule out than the other spine. In cervical spine or in lumbar spine. In thoracic spine, because the lungs, spinal cord, everything is in such a close proximity, we when we take history, we have to ensure that all these things are taken into account. That's why you'd ask them about their respiratory history, their medical history, history of cancer, TB, osteoporosis. It is very important. And without thorough history, I think you will never have full idea of what may be happening. Um, and this is why ask everything about past medical history. That is very important. Neurological examination is absolutely vital. Uh, Assessment of thoracic spine cannot be completed without full neurological examination, and in that we have to rule out any upper motor neuron signs. That's very, very important. If they have lower motor neuron signs, then obviously uh, it's a different thing. Then you would also assess the lumbar spine a bit more, and that's slightly, I wouldn't say easier, but that's slightly less concerning sometimes. Uh, do no harm. What I mean by that is, we shouldn't be start treating thoracic spine with physiotherapy interventions if they have obvious red flags. We have to rule everything out, and if we do, then that's fine. We have to work as a team with the other consultants, and that's why I say do no harm. We involve the consultants, we involve other medical professionals as well if required. Take their opinion, uh, work as a team, and start treating it if there are no concerning features. And obviously, the other thing is we speak with the spinal consultants when we are in doubt. That's the main important thing. Um, so that's pretty much the thing about thoracic spinal pain. Um, I hope it was a bit clear. I hope it gives some sort of information about how thoracic spine is slightly different compared to cervical and lumbar spine. Um, I think it was it is right when you mentioned earlier that it is slightly more neglected part of the spine than the cervical and thoracic spine. It is very important that we take thoracic spine extremely seriously, um, because there are more non-musculoskeletal issues than there are musculoskeletal issues when it comes to thoracic spine. And we often get referred patients with mid-back pain, but we have to assess. We have to take that referral with a pinch of salt sometimes, and ask and start fresh. Always start fresh, as if you have not been given any history. Ask everything about their pain. Ask everything about their past medical history. do thorough neurological examination. If you're concerned, speak with the consultants or your seniors, um, and just work as a team. That's the main thing. I hope it was useful. Um, yeah, that's all I wanted to add about thoracic spinal pain. Um,
Thank you, sir.
okay,
Sir, I have two questions I would like to
of
ask
course.
you. May I, sir?
Yeah, of
Yes.
course.
Sir, yes, sir. Sir, I wanted to ask how to differentiate whether the thoracic pain is originating from cervical or it is mainly the thoracic pain, which
Yeah.
is
So
there. Right?
yeah, so
Huh.
that's a very good question. I think it is um, often pain around the scapula can come from cervical spine, which is very important. When it comes to thoracic spine, spinal pain from cervical spine, patients often get some neck pain as well. So that is one thing. So you'd ask thoroughly about their neck symptoms, if they have got restriction in their neck movements and so on. We'll ask them about their upper limb symptoms as well, because C4, C7 nerve roots can give quite significant pain posteriorly. You would do a Sperling test, that is quite important. So you would ask the patient to sit first neutral, put pressure onto the cervical spine from the top. If the pain gets worse around thoracic spine with some paresthesia in the hand, then you can say yes, probably it is a cervical spinal cause. And then you would palpate the thoracic spine as well. If thoracic spinal has no focal tenderness, then and they've got neck pain, then you would say more than likely on the balance of probability, I would say cervical spine. That's probably the causing factor. And thoracic spine, usually when it's a problem, it's a very isolated, localized problem. You wouldn't usually get quite significant. You might get some simple neck pain, but the neck, that's the cause, then the neck pain is far worse than thoracic spinal pain.
Okay. So one more question. So
Of course.
usually we get a lot of ergonomic advice when there is low back pain.
Yeah.
But what ergonomic advice should we give when there is thoracic pain?
Yeah. Thoracic spine is quite peculiar. It's very stiff and rigid to begin with. So voluntarily, there is only so much you can do to
Yes.
correct the advice. Um, but the ergonomic advice is persistent flexion can cause quite significant rhomboid and latissimus dorsi pain. Uh, and if you can undo that, that's half the battle. So avoid persistent flexion. So if you can, kind of basically time yourself and work on, kind of keeping yourself upright. Make sure you're stretching your pecs as well every so often, and make sure that your angle of the seat is not very flexed. It is very important that we keep it at 90 degrees or slightly obtuse, so we don't flex all the time. There was a colleague of mine, I think here, he was very big on braces, putting something on for ergonomic advice, just to keep it upright. But
Yes.
uh, with that, uh, often a lot of reliance is on the brace. So you don't use your muscles quite a bit. You will have an element of deconditioning. I think if we have wonderful structures around the thoracic, they're so strong and big muscles, might as well use them. So I think working on your latissimus dorsi, your rhomboids muscles, timing yourself, sitting in front of a desk, not slouch for too long. Literally, after every 10, 15 minutes, if you can just stretch backwards, that's quite important. And when you're bending or picking something up, of course, going from your hips. That's so. These are, I think we all know, these are very, very, very simple measures. I mean, this is our bread and butter, but we forget it. That's the thing. All the patients tend to forget it. That's the problem. But yeah, just to reinforce that is an important aspect of it.
Okay, sir. Okay, thank you so much, sir. It has been a
Thank you.
privilege to learn more about this topic from someone like you. Thank
Thank
you
you.
for helping us become more aware for the factors of thoracic pain and sharing your clinical expertise. This
No
has
problem.
surely nudged us to put our thinking hats on and inspired us to look at the thoracic pain in a different light. Okay, thank you so much, sir.
I'm
And I
glad.
would also like to thank Physio TV for hosting this session and Sancheti Institute College of Physiotherapy for giving us this platform where we are learning continuously. I would also like to thank technical team for having our back. Their guidance is really necessary for us to sail through these sessions. Before signing off, I would like to thank our viewers. I hope you all will keep connecting with us on this platform for coming sessions and events. I hope we all are inspired enough to actually integrate new knowledge that we have got today with our conventional plan of care to maximize the patient benefit. Okay, thank you.
Thank
Thank you,
you.
sir.
Thank you for calling. Thank you.
Yes, thank you.